let's say I move from New York City to your area of St. Louis.
You're going to come work for me?
No, no,
with
no,
Thank
no.
you.
I'm saying,
You guys heard
let's say
it.
I move to St. Louis and I have back pain or shoulder pain or whatever. I call you guys up. I don't have insurance set up yet. What are you telling me over the phone?
Well, first of all,
Hey, welcome back to the Dave Kittle Show. Today we have Michael Gorman back on the show. He's a friend and a colleague and a frequent flyer. I think this is maybe your third time back on the show. Is that correct?
third time, Dave. Yes, sir. Yes, sir.
All right. The most popular physical therapist, the best physical therapist in St. Louis Metro. Michael, you have iMove Physical Therapy. You previously sold a 7-location practice to NovaCare Select Medical. We talked about it before. So if you guys are interested in that whole experience, if he had any regrets or not, if he loved it, if he hated it, you have to check out the Dave Kittle Show and go search Michael Gorman as part of the Dave Kittle Show from previous episodes. But today, we're going to talk about a couple things. We're just doing a little pre-interview, Mike, and we were talking about the future of physical therapy. We were just talking about in the pre-interview and recently over emails going back and forth about this. We want to talk about one-on-one care and the future of physical therapy, patients and clients, the end consumer paying out of pocket for the service, for the actual therapy service. We're going to maybe talk about pricing and offers and dollar amounts. One other thing that you just mentioned about how come practices don't have tiered pricing, almost like a law firm, like a senior partner versus a junior partner. That's how law firms do it. Physical therapy practices typically don't do that. What would be an intro to get started today?
Dave, well, first of all, thank you. This is, I believe, third time on the show, first time in probably a little bit, but thank you. You and I communicate quite a bit, and I always admire what you and your colleagues are doing. And it's just a joy. It's always a joy to be on here. But I wanted just to talk with you. We were texting back and forth just about a few weeks ago about, maybe what is our future? What is the future of physical therapy? Where are we headed? Because I think it's changed so much. But I wanted to go back to kind of where it all started. So I graduated in 1993 from the University of Missouri, but I graduated in 1993 and I knew I wanted to go into a private practice, and I knew that one day I wanted to have my own, but private practice back then did not include practices that were out of network or self-pay. And at least as far as I know, there was none of those. And you pretty much, if you wanted to become a private practice owner, you open your practice, you would market to physicians, and you would become more well-known, and then word of mouth started to happen. And that's how back in 2002, that's how I built my first practice. I had only been in St. Louis treating for 4 years at that time, but I knew I wanted something else. But my practice back then and what I had for 15 years was in network. And it was the kind of practice where, we would see patients every half hour. So you would be multitasking all day long. And it was exhausting. And so I did that for a long time. But like everybody else that is a private practice owner, we were fed up with the insurance reimbursement. We tried a variety of things. We got very involved with my state chapter. We tried to pass a bill down in our state capital, which was equal pay for equal services, because that to me made sense. I never understood why a PT working for a hospital group the hospital was getting paid whatever it was back then, $275 a visit, and I was getting $60. Anyway, so the bill in the first year almost got through, but then we had enough opposition that the bill was never reintroduced. Did that. I also did something which was called MIRA, which was Midwest Independent Rehab Association, trying to band together private practice clinics. We all had different tax IDs, so we couldn't go at it that way, but there's a way to do it. I think, Dave, it's a managed service organization or something like that. I forget. That was a long time ago. We just didn't have enough size to make an impact on any kind of negotiations. And we also found that other outpatient private practice owners weren't willing to walk away from really crappy paying contracts. I mean, we're talking like $43 a visit. So anyway, after all that, I did decide to sell to a national company. I sold to Select Medical in 2017 because I knew that I couldn't grow it anymore and it wasn't going to change. So when I came back into private practice in 2020, I knew that I didn't want to do it that way again. And so I opened up iMovePT in 2020. It was at that time a mobile company only. And obviously when you're doing mobile like you do, Dave, it is one-on-one. And that to me was very exciting. I can no longer treat 2 and 3 people at a time. I'm getting too old for that. So we opened up iMovePT, and then we opened up our first outpatient clinic in St. Louis in 2023, and we are one-on-one, but we are in network with Medicare Part B only, and everyone else is either out of network or self-pay. And that's how our practice is, whether it's mobile or outpatient, and I do feel like that is the future for private practice. I don't know how a private practice can open now and realistically, a small private practice realistically think that they'll be able to, I won't say survive. I think anyone can survive, but why can't we thrive? Who wants to just survive? I mean, we have a lot of education, so much knowledge, caring for people.
And a lot of value. We deliver a lot of value.
So much value. And so why shouldn't we thrive? We should absolutely thrive. But I will tell everyone that's listening to this podcast now, I guess the only way you can thrive with an in-network practice is if you're treating multiple people at a time. And that gives our profession, ultimately, I feel, a very bad name. I think we all know people that once they find out that we're PTs, are like, oh, I had PT last.
Can you give the story you mentioned in the pre-interview?
Yeah. So yesterday we moved my dad and stepmom out of their house. They'd been in their house for 42 years. So we hired movers, but I was there, we were there to help out. And so one of the movers found out that I was a PT. Well, he was talking about his back, and he had 2 back surgeries. And finally, the second one was a fusion, and that worked great, and he doesn't have pain anymore. And so he found out I was a PT, and he kind of went off on it. He kind of said, well, that didn't do anything for me, didn't help at all. I said, well, where did you go? And I won't say where he went, but I said, what did you have done? He goes, well, I went in there, and they talked to me for like 2 minutes, 3 minutes, and then he pointed me to do different exercises while they were working with other people. And I said, well, you got bad PT. He goes, well, it was just, no, I don't think it's good at all. I'm like, well, you went to the wrong place. Well, he didn't know where to go. I think it was workers' comp. He just went wherever they told him to go.
Right.
But so many people, I hear that story a lot. And then I'm always had to say, well, you know what? Try our practice. We're not that way. One provider treats one patient at a time. But unfortunately, if you have the insurance model, ultimately you have no choice but to really do that. And so my opinion, and what you and I were talking about, is I do feel the future of private practice, if you're going to thrive, because who wants to survive? No one. We want to thrive, is to go to self-pay out-of-network model where you offer things that are different.
Like what?
Like newbie direct current electrical stimulation. We have that in the clinic, and also 3 of my mobile franchisees use it. We do HRV diagnostic testing, we've been doing this for about 3 months. It's been fantastic. Gives us a peek inside a patient's autonomic nervous system. And it's data, and it kind of wows that patient.
Is that with the mask and they're on a treadmill?
No. What we do is it's a super simple test. It's you put wrist clamps on it, measures 300 heartbeats. It's doing an EKG, and then it spits out a bunch of data relating to their autonomic nervous system. Because, not to get us off track, but patients that have chronic pain, their sympathetic nervous system is most times in overdrive. And we know that patients have a hard time healing. We've always had a hard time, having true data to back it up. But now with this, it's amazing. If anyone wants to reach out to ask me what's going on with it, I'll point you in the direction of who I bought it from, and we can go from there. But that's been again, getting us into optimal wellness.
With that, you're putting wrist straps or clamps on the patient, and they're then walking on the treadmill or running or jogging on the treadmill, or just sitting there, or what?
Nope, they're just laying down. They're laying down. It's about however long it takes to get 300 heartbeats. So it's about a 4 or 5 minute test. And then you get immediate data. So the computer spits out all this data, and I take selected portions of that data, go over it with that patient. And if their autonomic nervous system is out of whack, there's a setting on the newbie called the master reset that's specifically to reset its vagus nerve stimulation. And so, again, these are things that we would have never heard of back in 2002.
Yeah.
So as technology has changed, if you don't embrace it, then you're going to have sort of an older school practice. Again, nothing wrong with this, not for me. But if you take time with them, if you give quality care and you have technology and your product differentiators, if you don't have that, I do feel that an out-of-network self-pay practice is hard to have. Now, again, we are a Medicare Part B provider. We could spend hours talking about that. How much longer can we do that? I mean, if we continue to get 2.9% cuts every year, we're not far away from it not making sense. And I hate saying that because those people need the care the most.
Right.
But again, I want us to thrive.
Let's focus on your model. So do you do the HRV with every single patient, or that is like a cross-sell or an upsell offering?
So what we do is if the person's a patient, we do it in probably the second or third visit. We're doing the HRV testing. We're getting all this data. We're going through it with the patient. And then if their HRV autonomic nervous system is great, perfect. We might check in again in a month, but we don't really do any intervention. But if their HRV is in the tank, we tell them, here's the things that are going to happen to improve this. And so then the patient, part of it is newbie twice a week with the master reset. There's other things. We talk about meditation. I would never have thought about that in 2002 or 1993. We talk about sleep patterns. We talk about stress. We talk about, exercise, which we all do that anyway. And then we retest them in a month. Because if we just show somebody something and then we never follow up with it, they're going to lose interest. And I'm not trying to milk anything for anyone. If I have data, I'm going to show you, and we have tools in place that can improve that. We're going to do that. So that's what we've been doing. Starting in May, we're going to be offering, if someone hears about it on the street through social, and they want to just come in for HRV testing and then treatment for that, we're going to have a self-pay package for that.
Let's say I move from New York City to your area of St. Louis.
You're going to come work for me?
No.
Thank you.
I'm saying,
You guys heard it.
I move to St. Louis and I have back pain or shoulder pain or whatever. I call you guys up. I don't have insurance set up yet. What are you telling me over the phone?
Well, first of all, I'm a big fan of your friend and my friend Jerry Durham. Got to make sure when the patient, that out-of-network or self-pay patient, for the self-pay patient, we got to make sure to talk with them. Like Jerry always says, get the relationship established before you talk about price, whether it's self-pay or out-of-network. But for that patient, yeah, they would become self-pay. And if they squawk about the price, I always say, just schedule that first appointment. Just schedule that first appointment.
What are you charging these days? Like, how much would it be?
So we do $200 for the first appointment. And then if they're self-pay, we have package rates after that. So they can do a 3, 6, or 9 visit package, and that lowers the price. And so if they buy a 9 visit package, it comes down to average of like $153 a visit. I haven't raised prices for about 2 years. And, it's probably about time everyone else in the world has raised prices. I'm not someone, to be honest. I know you've had some guests that maybe charged $300-$400 and up. I don't know. In this area, I'm not sure how well that would go over, but I think there's some room to go up. But I think more important, and I don't know if you want to talk about it later or now, but kind of that tiered pricing.
Yeah, let's talk about it. So I met up with a buddy, Dr. Adam Gavilli, physical therapist in Manhattan, fairly newer brick and mortar practice. He was in a different gym before. Now he's got his own independent space. And I met up with him maybe a month or so ago, and we talked about this. We grabbed some food, and then we went back to his office. But he wasn't a fan of it. And I said, like, I've tested it when I was price anchoring patients, right? So I would say, like, let's say, all right, the inverse. Let's say, you, Mike, let's say if you were calling up, you were in the New York City area, you're calling up. Now, for me, I'm seeing like just 1 or 2 patient visits per week. I have a 12-month-old son at home, so like that's the main focus, and I'm not really going out to treat patients. I've even tested by saying like, well, on the phone with you, Mike, all right, well, you have back pain or whatever, and okay, so we go through the whole spiel, and then we get to the pricing, and then I've tested saying, well, they ask for the rates, we don't take your insurance, or your insurance does not have out-of-network benefits, so we can't bill it, so it would be 100% self-pay. And then I pause and I wait for you, Mike, to say, okay, well, how much? Because some people will say, oh, self-pay, I can't afford that. And they get off the phone, which is hilarious. Like, imagine saying no to something and you don't even know the cost. Like you're so far away from the self-pay understanding or value connection or whatever, or maybe I did a bad job on the phone or whatever. But some people convert and some people don't. Some people get off the phone without hearing the dollar amounts. They're obviously totally not my ideal client, and that's fine. That's okay. But I've tested saying, well, Mike, you asked for the rates. You say, well, how much is it? And then I say, okay, now that he asked, now I can go into it because I need you to kind of lean in a little bit. Mm-hmm. So you say, how much is it? Well, Mike, for me, if it were me treating now, for me, I'm not treating patients right now because I'm really busy. I got a son at home, whatever. For me, it would be $550 per visit, but I'm not even treating patients. So I say a higher dollar amount and I say, but my physical therapist, Porus Mehta or Dr. Mo or whoever is $350 per visit. And so my buddy, Dr. Adam Gavilli, didn't like that because he says it could devalue the view of the staff physical therapist that they're then getting because he wasn't a fan of it. I haven't had it blow back in my face or blow up, but your idea of saying, so in the pre-interview, you said you had like a newer grad that didn't work out in your practice, was not able to keep a full schedule or build up to a full schedule. Maybe there was a lack of confidence, maybe, or clinical chops or multiple things. And you were saying like, maybe if you pitched your, whatever, $200 evaluation to the person over the phone, but then you had this new grad and their rate is, I don't know, 125 or 150. I don't know how much you're going to, cut off the dollar amount. There's pros and cons. One, I think some people might look at that and say, well, why is their rate so much lower? Are they that bad? But then there might be other people that say, well, they understand the law firm, senior partner, junior partner, you can save some money. So if someone is more budget focused, they heard about you, they read your Google reviews, they want to start with your practice. But if budget is truly their main concern, but they want to move forward, this could be more accessible to more people. So I think it might be something to maybe test out. I don't know.
I think it's important to give people options. I think it's super important to give people options. So although we don't do it yet, I'm not going to say we're not going to, but we don't do the tiered pricing yet. But it could be, yeah. I could see there would be people say, oh, Mike, I can't afford your $300. But, Joe, we're more than happy to spend $200 on him. I don't think it really devalues anyone. That's still a pretty healthy price.
Sure.
I mean, I don't think anyone would be devalued. And because when you and I have gone to attorney offices or any private or any business owner has dealt with an attorney, I don't look at the junior partner or the new associate. I don't look at them as, I don't really devalue them. I don't think of less of them. I get it. I understand why he or she is not as much as the lead dog. I mean, I know how much I pay for a McDonald's burger versus Ruth Chris hamburger. I get it. I mean, it's, it's not that one's worse. It's just different. So I don't know.
Yeah, you might have to test it if you hire a new grad or so, someone that has less worldly experience, less clinical skill set. They are pretty, green and they're novice. Maybe you test it.
Yeah. But I will say something really important. I know we're probably getting off track, but one thing I've started saying when I'm talking with an out-of-network or self-pay patient, and we're kind of starting to talk about the price, and they push back or like, yeah, I really wasn't thinking it's going to be that expensive. I always say, look, you know what? I understand. This isn't for everyone. I say, but, and I'm on the phone with them, but I'm looking at that phone, staring at that phone. Said, please do me a favor, and wherever you go, make sure that you go somewhere where they're going to give you one-on-one care and the attention you deserve, because that's what you need. I said, so please promise me you'll not go to a place where you're going to be treated. One therapist is treating 2, 3, sometimes 4 patients at one time. I said, please do that for me. And it's worked. I mean, again, I'm not.
Now, how often do people go to the other place, then call you back and say, oh, you were right, it was like that?
You know what? In a year and a half, I haven't had anyone. The outpatient clinic's been open a year and a half. We haven't had anyone. I don't believe we've had anyone, but we've had many people, or I'll say, you know what? Just come in one time. Come in one time for the evaluation, because I don't even know if I'm the right provider for you. I said, I think I am, but let's do the evaluation. I'll tell you what I find. And then, you know what? If you don't want to come back again, I'll give you a plan, or I'll try to refer you to someone that maybe is in network. I said, but just come that first time. Because you just have to get the patient in your door, or if you're mobile, you just got to get into their door, and the services that we do and the care that we give, it sells itself. And I can easily recall off the top of my head quickly 5 patients that have said, okay, I'll come in one time. And they turned into patients that lasted, self-pay patients or out of network, that lasted for weeks. Again, I'm not trying to milk anything. I'm just saying you need care. I am too busy to treat people that don't need care. But so those are just ways I kind of handle it when there's a financial pushback. But you got to you got to paint that picture of what the reality of an in-network practice is. And I'm not talking bad about those therapists in those clinics. They don't have a choice.
Right.
Choice.
Before you're going into pricing, do you speak to prospective patients and ask them, like, have you had this issue before? Did you seek treatment before? What type of treatment did you seek? Was it physical therapy? Did you acupuncture, chiropractic? Like, do you kind of get into that to understand, like, and then kind of you want to find out, like, what was their experience? So you want to make sure, if you're speaking to someone, you want to make sure if it's like that mover, the mover who, I mean, he's probably not going to be calling you, but if he or she was, you want to make sure you find out how their history was with whatever this issue is, or a different issue, what type of treatment that they had or sought. How did it go? Did they like it? Did they love it? Did they, and typically what I do is I want to dig into, like, if they had physical therapy before, I will literally say, oh, so you had Fox Rehab before, or you went to Spear Physical Therapy or wherever, like, oh, yeah, so you went there before, like, so I'm curious, like, you're calling around now, you found us on Google, you said, or whatever. Why aren't you going back to where you had physical therapy before? And I want to hear what they say, because then whatever they say is, if they say things like, well, I want more one-on-one care, and, we went to this other place and it was so loud and the therapists were on their phones and it was like a ton of patients being treated at the same time. Now they're selling themselves.
Yeah, I don't normally on the phone. I don't normally go into that kind of depth, because I know I don't think there's anyone in this city that's doing what we're doing here. And so,
but it helps to aggravate. It helps to agitate their problem, so that then they'll have more of that built up before you drop the pricing on them.
It's true.
So now the pricing makes more sense, because you've already agitated the problem of, here's the things that they went through before. What did they try? Here's their issue. I don't know. Those are some of the things that have helped me and helped us with demonstrating value over the phone before we discuss insurance and cost?
Yeah, I think you get a feel, because as you know, when you're talking with either an out-of-network or self-pay practice, every phone conversation, it's a different conversation. And so you just kind of got to go with it. I definitely tell them about our practice. I definitely tell them, we're an out-of-network or we're self-pay practice, and here's why. And I simply tell them, I said, I'm not going to be confined by insurance policy or insurance reimbursement, because then I can't give the kind of care that you should have. And yeah, you know what? And it's really important to understand, if you do have an out-of-network or self-pay practice, just don't get upset if you don't convert everybody. We're not gonna, I would say the people that I get on the phone, because, they call into the clinic or they call our patient care rep offsite if they're mobile, and they'll get all the insurance information. They get it to us, and then we make the call back. Because I want to talk with that patient, because you will have a much better chance of conversion if the owner gets on, than if you have the front desk call back. And no offense to any front desk, they're great people, but these are important people to me. So we want to really make sure that we convert. So I think we convert about 40% maybe of the out-of-network patients. So I'm not upset about that.
Excellent. Where are most of your patients coming from? Is it Google? Is it online ads? Is it word of mouth from previous patients? Is it from community outreach and, popping up a booth at a health fair? Where do you get patients from?
I would say it's really scattered, but we try to get 60% of our patients. That's our goal. 60% of our referrals to be past patients or friends of past patients, friends and family referrals. Because that's just to me, that's low-hanging fruit. That's if you do a good job, those patients of yours will tell others about you. And so that is our goal. So when we're looking at our stats every month, we like to see 60% fall into that category. But we have started doing, I'd say we've been doing Google ads for over a year and a half. And the first 9 months, I wanted to go crazy because we weren't gaining much traction. And it definitely takes time. And we don't spend like you do, but I admire you. And again, you're in a much different community where I think that really makes sense. But we definitely have kept with it. And now I'd say, I don't know, maybe in a month, 5, I'm not going to say 5 referrals, but we'll get 5 calls from people that specifically say, well, we saw your Google ad, or we saw you in Google, or whatever. And I think that's obviously talking about change and what the future is. I do think that is the future of private practice PT, because, we've all done a physician lunch where we go in and we essentially have to feed an office to get 2 minutes with whatever it is, orthopedic surgeon or whatever. And I've done so many of those in the past. And for me, I can just tell you my experience. I'm done with that. We'll still do physician lunches, but it's with concierge physicians, because those are the people that get it.
Right.
They know, because we're very similar practice. No, we don't have a concierge fee, but I look at us as a concierge practice. And so they get it. So there's so much less to win over our market. They just get it. And they want their patients to get the care that they give their patients when they refer to a PT. So I don't do those anymore. I don't do those big lunches anymore. So,
with the concierge physicians, this is one thing that I've been doing, which is, let me see if I got them handy. We'll get referrals from these concierge practices, and they never spoke with them before. The office manager or whoever must have found us on Google or something, and then they're calling up and they're like, hey, we have a patient, and do you take this insurance, or how much is it, or whatever, and they live at this intersection, do you guys cover this area, whatever. Here's my game plan after that happens. I would love to get your feedback. So what happens is, I've never marketed to these concierge physicians. Now I am, but initially, over the past, let's say 2 years or so, we'll get a referral, and it's either the patient, but typically it's like someone from the concierge office, like the office manager or whoever is calling on behalf of the patient. And then we get like the phone number from that concierge physician's office. Obviously they say it's from whoever, doctor, whoever. And here's the patient's name and address and phone number. Feel free to reach out to them directly, or if they want us to call the concierge physician office back. This is my approach. First of all, obviously I want to call the office and I want to say, hey, thank you for the potential referral. We're going to contact them. And yes, we service that area or whatever. I want to find out, obviously, like how the referrals are done and who does the referrals in that office. Mm-hmm. And then what I've done is I get these little thank you cards. So this is my concierge pain relief card, a little handwritten card with like my little signature contact information on the bottom. We are seeing patients like you guys out of an office in Manhattan now, plus the home visits. So the office location is on there.
What?
Yeah.
What?
Yeah.
I didn't. You have this now?
It's like a sublet kind of, per the hour per, so it's like, it's just dipping our toes in.
Okay. Congrats.
And actually I pursued that because I had a few patients that we were seeing in the city, used to live in the area, and in the last year or two moved to New Jersey or Long Island or whatever, and now they're taking the train in. And I would say to those patients that I was seeing for the last 2, 3, 4, whatever years, you have aches, pains, whatever, like, let's keep it going. Let me treat you. I can come in your office because we've been in boardrooms, hedge funds, law firms. We can go in certain offices if there's space or a bench or a couch or whatever. With this one particular client that I had for 4 years, he's like, yeah, we have glass walls, like, and there's just no place. And he knows I'm not bringing a table. So I'm like, do you have like a wellness room, like a massage room? Like, do you have like a gym, whatever? No, nothing. And I thought, well, let me contact my buddy that's got an office nearby, and started doing that. So that office has like portable treatment tables that we can pop up, extra exam rooms that we can use, some therapeutic exercise equipment, whatever. So now we're doing a little bit of that brick and mortar, but still with the one-on-one, obviously, and like out-of-network insurance and self-pay.
Hey, it's Dave Kittle. Are you a healthcare business owner or physical therapy practice owner who is looking to figure out your succession plan or exit strategy? We might be able to help. And in fact, we may be interested in acquiring your practice. If you're interested, you can reach out to me. Shoot me an email at dave@conciergepainrelief.com. That's DAVE@CONCIERGE painrelief.com. Or you can call me at any time, 646-781-8884.